Hello, I'm Dr. Paul Conley. Thanks for tuning in to another episode of Doc Talk. So this evening we're in Fayetteville, West Virginia, and my guest today is actually Dr. Martin Mrozek. Dr. Mrozek has been here for quite some time. He's our local foot and ankle specialist, also known as a podiatrist. Dr. Mrozek is on staff here at Plateau Medical Center. And Dr. Mrozek works on staff, and many times when I see him in the operating room, it is because someone has a diabetic issue, such as a diabetic foot ulcer that needs debridement, or maybe even where they have to have an amputation. And so tonight we're going to talk to Dr. Mrozek about diabetes, but more importantly, what does diabetes do to the body? And in our show tonight, we're going to talk about the foot. So thanks for coming on, Dr. Mrozek. We've been here before, and you've talked about diabetic feet, but I think it's such an important topic that I wanted to bring you back on the show again so we can talk more about diabetic feet. So appreciate you coming. So foot and ankle doctor, so a podiatrist, maybe just before we even dive into diabetic feet, for the audience out there, what exactly is a podiatrist, and what part of the body do you focus on?
Well, podiatrist is like you said, foot and ankle specialist. We have specialized schooling and training. You know, the first 2 years of our medical school is similar to allopathic or osteopathic medicine, you know, all the basic sciences. But then we tend to focus primarily on the lower extremity the second half of the second year and the last 2 years, as well as clinically. So, you know, we see a lot of diabetics in terms of you know, foot and ankle issues, and that's one of the many things we take care of, you know, overall. But unfortunately, sometimes it's one of the primary things, you know, that becomes an issue.
Well, I mean, obviously we're here in Central West Virginia, and so, you know, we've done shows in the past. We did an episode not too long ago with Dr. Charles Burdett, also here in Fayetteville, and you know, we just talked about the importance of diabetes. We also know in this country that unfortunately in the U.S., obesity has become a problem, and as we get bigger and heavier, diabetes is on the rise. And so when we think about diabetes, you know, we think about heart disease, we think about how it affects our vision, we think about how it can affect our kidneys and dialysis. But in our show tonight, we're going to talk about how it affects the feet and even just the lower extremities. So again, as a podiatrist, you're pretty much anything from the knee down. Is that correct? That's pretty much your focus?
Yes. Primarily ankle and foot, but we do some other issues in the lower extremity in terms of circulation and things of that nature.
Because, you know, I think a lot of people, you know, a lot of times, you know, orthopedists, they pretty much, at least here locally, seems like they tend to send you the foot and ankle things. I mean, I know there are some specialty orthopods, but a lot of the general orthopedists tend to focus more on hip replacement, knee replacement, shoulders, injections, things like that. But when it comes to foot and ankle, that's kind of your guys, a podiatrist. That's pretty much, you know, your wheelhouse.
Yeah, I mean, it's our bread and butter, and, you know, we do, you know, coordinate care with, you know, some of the orthopedists, and like you said, a lot of times they're, you know, overwhelmed with the rest of the body and, you know, tend to want to, you know, defer or refer, you know, those folks to us.
So I'm a diabetic, and so I am watching the show, and I've never had my feet actually examined, checked out. So if you're a diabetic and you're watching the show, whether you're a type 2 or a type 1, and you have diabetes, what actually should that patient be doing? You know, foot exam, ankle exam, you know, tell me a little bit about, if you're a diabetic and you're watching the show, you know, what should I be thinking about, and what should I be concerned about, and what should I be doing?
Well, you know, first of all, you know, having tight glycemic control, you know, good control of your blood sugars is, you know, the penultimate thing that, you know, all the physicians want our diabetic patients, you know, because that's where a lot of that starts, you know. But as far as, you know, the feet themselves, you know, we always try and educate folks on checking their feet regularly, daily. If they can't see their feet, have someone else that's available, to, spouse, significant other, look at their feet as well. If they can't turn their foot up to, take a look at the bottom of the foot. Or also a lot of times we'll have them utilize a mirror to be able to, visualize what's on what they can't see otherwise. It's important they do that, regularly, if not daily, before or after, showering or bathing is, always a good time for that as well.
Well, I know in internal medicine, it was one of those things, if we had a diabetic come through the clinic, the medicine clinic, we would always want to make sure we're taking off their shoes and checking their feet. But I guess maybe I should walk and take a step back. What exactly, when we think about diabetes and diabetic feet, I know we think about the people that have something called diabetic neuropathy, which I think is what kind of starts down that path, because once you develop the neuropathy, then you start losing sensation. I think those are the people that are maybe of more concern because they don't even feel the bottoms of their feet. So maybe you can explain to the audience, what is it about diabetes that is so problematic as far as a diabetic foot?
Well, like you said, one of the primary issues is the diabetic neuropathy, which is damage to the nerves that, go into the feet. I like to tell my patients, when you have diabetic neuropathy, it's like having a wire that short circuits. The insulation off the nerves gets damaged due to high blood sugar, and then consequently it starts a vicious cycle of, damage to the nerve not working properly, and there can be a lot of, symptoms in that regard, anything from pain, numbness, burning, tingling, pins and needles, stabbing, shooting, and as that progresses, that tends to get worse in terms of my feet hurt all the time. I can't sleep. It causes stress. When they have stress, their blood sugar goes up, which causes the nerves to be damaged more. So, those are a lot of the things that kind of get that ball rolling downhill, and even when you can start to get that blood sugar under control, sometimes the damage is already done.
I know that's one of the things that I think people need to understand, how important it is that you get in front of this early, because I do think that's something that we see, is that you'll have someone that has uncontrolled diabetes, but then when they start developing the burning, the stinging, that's where those nerves are suffering the damage. That if they then get the sugar back under control, not always will the burning and the stinging and the neuropathy resolve. There is a point of no return, that then even though you may get that A1C, which our goal is always below 7%, we like to see it even lower than that, but definitely that's kind of a benchmark. But I've had patients that even though they get their sugar under tight control, get that A1C 6%, let's say, but they still have neuropathy, and that's because of that damage. Because once you damage nerves are kind of an interesting thing. Once they get damaged, very difficult for those nerves to regenerate and come back.
That's correct. Yeah. And that's, like I said, with the early detection of the neuropathy, a lot of times we can stall that progression out, with combination of their primary care or endocrinologist. It does take a team effort, and as well as their support, their family, in terms of being able to have proper nutrition and exercise and, things of that nature.
Yeah, I do think that one of the things that I see in my office, because I see a lot of people that have fatty liver disease from their diabetes. That's exactly right. The neuropathy in some ways they think that maybe after the burning and stinging kind of goes away to where they don't feel anything, they actually think that's a good thing because the burning and stinging goes away. But actually, that's a bad thing because now they have no sensation in their feet at all, and then those are the people that are really set up for these adverse complications. So it gets back to just like you said. I mean, diet, exercise, tight glycemic control, and make sure when you're seeing your primary care provider that that you're getting that you are getting a foot examination. And so in your situation as a podiatrist, when you have that patient, when you're talking about doing a foot examination, what are some of the things that you do? I know when I was a resident, we would talk about testing for proprioception. We'd test for sensation, or those things that you do here in the clinic when you have that with that diabetic.
Well, when we do a diabetic exam, the first thing is just a visual exam of their feet. Is there any dry skin? Is there discoloration? Is there swelling? And then once we do that, are there any deformities? Do they have hammer toes or a bunion that could cause a pressure point, or a callus that could become a wound down the road? But then when you're talking more about the neuropathy, there's a few different tests. Typically, we start out with what they call the monofilament test, where it's basically like a piece of fishing line, and you poke the patient's foot to see if they can feel that. And it's a very light, touch. So if there's nerve damage, sometimes those people can't feel it. Then, like you said, the proprioception to check, see, if they can feel, where they're at in terms of, standing, on the ground in terms of balance. Then we also use a tuning fork. We check, the vibratory sensation. We put that on multiple places on the foot, see if they can feel it vibrating, and then more importantly, if they can, they tell us when it stops vibrating, and that will give us a baseline that we can compare down the road as to, is their vibratory sensation worse, or their monofilament sensation worse? And those are all indicators of progression of the neuropathy.
Right, and I would imagine that if, to your point, the proprioception, that's where you take the toe and you bend it up, bend it down, and it's amazing how I guess I just take that for granted that you can tell when you're toe up, toe down, and these people can't tell that. And then you think, well, that's where grandma gets up in the middle of the night to go to the bathroom. She can't really feel her feet, and then she falls, and then she breaks her hip. And the broken hip was because of her diabetic neuropathy caused her to fall and break a hip. So, well, it looks like as I look at our light bar here, we're almost up for a commercial break. So when we come back, Dr. Mrozek, I want to shift gears a little bit. What I want to do is I want you to talk to us a little bit about prevention of diabetic foot. As you can see, we have all kinds of shoes here. I want you to tell the viewing audience what type of shoes we should be wearing. I want you to talk a little bit about diabetic shoes, the importance of that. I also want you to talk about how we can prevent that dreaded diabetic foot ulcers. So I'm Dr. Paul Conley. I'm here with Dr. Martin Mrozek. We're here talking about diabetic feet. We're going to take a commercial break. Stay tuned because we're going to come right back.
You're watching Doc Talk with Dr. Paul Conley on WZTS 16 Cozy TV. Stay with us. We'll be right back after these messages.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we're delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.
Welcome back. Doc Talk with Dr. Paul Conley continues on WZTS 16 Cozy TV.
I'm Dr. Paul Conley. Thanks for tuning back to Doc Talk. So I'm here with Dr. Martin Mrozek. We're here in Fayetteville, West Virginia, and we've been talking about diabetes and how it affects the feet. So Dr. Mrozek, our podiatrist here on staff, has been talking about diabetic feet, and we've been talking about neuropathy. So right up to the break, we talked about what neuropathy is and the burning, the stinging, and we talked about how you lose proprioception. Proprioception basically just means the sense of where you are in space. We're talking about how that's where, you can't really feel your feet. You're kind of walking down a set of steps and you're kind of like trying to feel your feet and trying to see if am I at the bottom step or am not bottom step. And, so there's an increased risk of fall. And obviously when you think about falling, then you could have head injury or broken hip, broken bone, what have you. So now I've been diagnosed with diabetes and diabetic neuropathy. You've already diagnosed me with that. So I'm going to say, all right, Dr. Mrozek, you diagnosed me with having diabetic neuropathy. Moving forward, so I don't end up having, that diabetic foot ulcer, which has all kinds of adverse, downstream, effects such as an ulcer, osteomyelitis, which is bone infection, what have you. What can I do to prevent that ulcer, or if I were to develop an ulcer, how would I be able to detect that early enough that maybe I could have an ulcer that wouldn't be limb threatening?
Well, there's a lot of different things that we can utilize in terms of one, trying to prevent those, and two, obviously on treating them if that becomes that situation. First of all, like we talked about earlier, the foot exams at home, as well as, we had talked about prior to coming on camera about people wearing light-colored socks, white socks, or light-colored socks. That way, if there is anything going on their foot, they've got a scrape that's bleeding, or they have a wound that they didn't know about that's draining, there'll be visual evidence, for them to see, on their sock when they take it off. Once there is an issue, then obviously, there's time to call in reinforcements, be it, through primary care or through our office in terms of, trying to effectively manage that wound and get it healed, because there is a significant, morbidity and mortality, with wounds that, like you said, may get, osteomyelitis or bone infection.
So, one of the things when we're talking about at the break, and we're talking about just the importance of wearing like white socks, you kind of think, well, that doesn't seem like that would make a big difference, but you're right. I mean, so if you have white socks, you take your sock off and you see a little hint of blood or a little bit of a yellow stain, then that could definitely lead you on that you may have a little skin breakdown, which is the beginning of a diabetic ulcer. And if you have neuropathy, you're just not going to feel it. We've had patients that will, in some ways, kind of brag about the fact, hey, I can step on a hot coal or I can walk on glass, and you know what? I don't even feel that. And we both know that that's, pain is the body's way of avoidance, and so when you have diabetic neuropathy, you could step on a tack, right? Step on a nail, a gravel in your shoe that you would never feel. So speaking about shoes, as a diabetic, even throughout the house, barefoot, not barefoot, wearing slippers, Crocs, what are the thoughts about a diabetic has neuropathy and going barefoot?
Well, that's one of my cardinal rules that I try to reinforce to all my diabetics, whether they have neuropathy or not, is that they definitely do not want to go barefoot. Very least, house shoes, or like you said, Crocs are a great option, as long as they don't have an issue with, falling out of them or slipping out of them, causing fall risk. But going barefoot is an issue in terms of the causing wounds, and it could be anything from stubbing your toe. If you don't have anything there to protect it, you could hit that toe and knock the toenail loose or get an abrasion on your toe that goes south.
One of the things I think when we think about with this whole realm of diabetes is, diabetics many times have an increased risk of, onychomycosis, which is toenail fungus, all right? And, some of these folks can have toenails that are really thick and hard. And I've seen where some of these people will try to trim their nails, and if they're not careful, they themselves can cause quite a bit of harm. So if you're a diabetic, when it comes to toenails and toe care, things like that, what are your recommendations for that individual?
Well, that's a very good point because, at least once a week I get folks coming in that, said, I can't cut my toenails, or every time I cut my toenails, my toes turn red because I get the skin with it, and, that's an area that, can cause an infection, fairly easily. So, I suggest or recommend they come and see us. They don't necessarily have to come to this office, but have somebody do them, especially if they're a diabetic. At a lot of times people have issues in terms of reaching their feet, and then, like you said, they have these big thick nails. Then they don't have anything that can adequately trim those nails, and I've heard everything over the years from, wire cutters, pocket knives. I even had a fellow use a hacksaw.
That's a thick nail.
So, yeah, and one slip of a pocket knife, and then you're, not only into the hide, but who knows where that pocket knife might have been.
Well, I think that's right. I mean, if you're using shears and pocket knives and stuff out of the garage, you're exactly right. I mean, pocket knife, like I said, might have been out there skinning a squirrel, and then you put it in your pocket, and now you're like, digging out an ingrown toenail. And so, when I think about that too, we think about diabetics. A lot of our diabetics, have heart disease, peripheral heart disease, and so many times, our diabetics will be on blood thinners, and so. You have a patient who's a diabetic, they got diabetic feet, they got, toenails that are somewhat going to be difficult to manage, a challenge to manage, and then you're on aspirin, Plavix, Eliquis, Xarelto, et cetera, et cetera, et cetera. I mean, then you can get in some significant bleeding, if you're taking, shears and hacksaws and stuff to your toes. So I think it's very important that you, seek a professional. And so when you have a diabetic that comes in to see you to have their toenails clipped, how often do they need to come back and have that done? Is that something you schedule routinely? Do they come back every so often?
Generally speaking, rotation's usually about every 2 months. And some of that depends on the individual patient. Some people's nails grow more than others, and some of it also depends on their activity level. If they're more sedentary, not getting around, sometimes the nails don't cause them any issue. But, for someone that we, obviously want to be active, to help overall health, cardiac health, circulation, glycemic control, that may be necessary to do it a little sooner than that.
So one of the things, if people watching the show, they notice we have this whole tree here of shoes, and so at the break, our camera guy, this shoe right here was untied. It was upsetting him, so we tied that. And then I said to you, now which of these shoes, Dr. Mrozek, are the diabetic shoes? And you said?
They're all diabetic shoes.
So which actually, I took a step back, because this shows you how ignorant I am when it comes to that. Because, in my mind, I guess maybe things have evolved, but I always think about, when I first started practice, I graduated medical school in 97, so like 30 years ago, I always thought of a diabetic shoe as like the Herman Munster, Frankenstein, just not very attractive type of shoe. And I thought, man, I don't know if I'd want to wear that thing or not. I mean, obviously, because if you see that, you're going to say, well, he must be diabetic. Look at those shoes. Like it almost would be like a HIPAA violation, like, oh, he's definitely got diabetes because who else would wear shoes that look like that? But these shoes right here, I mean, you couldn't tell at all. And some of these have laces. Other ones here have Velcro straps. So what is it about a diabetic shoe that is important versus, if you are to pick out shoes, if they're not diabetic shoes, what should one be looking for when they're buying shoes as a diabetic?
Well, if you're going to buy, regular off-the-shelf shoes or order, a lot of days, a lot of people order, online. But I would prefer that they go to the store and that they can try them on, But you're always wanting proper size. You don't want something too big. You don't want something too small. I always suggest that people go shopping later in the day when your feet might have swelled a little bit. If you go in the morning, your foot might be a little bit smaller, and then you get that shoe home and you wear it, and it's a little bit snug or might, rub an area on the foot. But you always want to make sure that the heel's not, going to be rubbing. You don't want any, blister formation. And everybody's foot's different in terms of width. You don't want to have something that's, too narrow. That obviously is going to cause problems. But conversely, if you've got a shoe that's too wide, your foot's going to shimmy and slide around inside, inside that shoe and cause, friction as well.
And I see here, like with these shoes, I mean, with this Velcro here, I mean, obviously, to your point, if your foot were to have some swelling in the afternoon, because unfortunately, as you know, diabetics can have heart issues, swelling issues. We talked about kidney issues, and sometimes these folks will have some edema. Some of the medications can cause edema as well. So when I look at this diabetic shoe, I mean, obviously, especially with the Velcro strap, I mean, that's very convenient as far as being able to get your foot in, your foot out, being able to adjust that accordingly. And if you have any issues with dexterity, you're not running around with your shoelaces untied to trip over. I'm bad about that. My nurses are all the time saying your shoe's untied, and I'm not going to
Yes, because even that could be a fall risk. If your shoe's untied and they're walking and they step on their lace, or somebody else steps on the lace, if you're in close proximity to another person. But the diabetic shoes, the really nice thing about those is they're made on the inside. There's very little to no seams, so there's no prominent areas for the patient's foot to be rubbing up against something. They also come with inserts, diabetic inserts, and typically each pair of shoes comes with 3 pair of inserts per year. So when they start to get worn out, you just pop them out and replace them. And those are, pliable. They give support, but they also give some cushion, and they're moldable. So they're molded, right to the individual's foot. So there's a decreased chance of, friction and sliding. We also use, custom inserts inside the diabetic shoes if, someone's had a previous ulcer and they have an area that's, prominent, or if they had an amputation, you can do a filler to, prevent their foot from moving around and causing more problems.
Well, it sounds good. It's 5 seconds left, so the crew's getting on to me. So diabetic shoes, there's a whole plethora here. Folks watching the show, if you have diabetes, make sure you're checking your feet. Make sure that if you have any signs or symptoms of neuropathy, that you get in to see your podiatrist. Dr. Martin Mrozek here in Fayetteville. I mean, he's obviously our expert here when it comes to diabetes and diabetic foot. And so, Dr. Mrozek, appreciate you for coming on the show. And we've been talking about diabetes and diabetic feet. I'm Dr. Conley, the host of Doc Talk. Until next time, have a good night.